Morning, Michael.
Morning, Stephen. How are you?
Very well, thank you. It's nice to see you again, sir. This is Dr. Michael Sinnott from Qlicksmart. Michael, I'd like you to introduce yourself to people and tell us a little bit about how you ended up where you are today.
Thank you, Stephen. I studied medicine at the University of Queensland when it was still an MBBS program, which took 6 years. When I completed my 6 years, I did an internship at the Gold Coast, and then I did my training to become an emergency physician. That was 3 years of residency and 3 years of registrar training. I was probably in the second or third group ever to do the exams in Australia, and I thought that the training was not quite as good as it could be, so I elected to then do my physician's training, which was another 5 years. Okay. When I completed my physician's training, I worked as a general physician in perioperative medicine for about 12 months before returning to the Princess Alexandra Hospital and working as a staff specialist in emergency medicine, which I did all up. I think I did about 35 years before I retired.
That's very significant. And over that time, you probably trained about, what, 4,000 junior doctors, 200 registrars?
Probably something like that, because we would have registrars would do a 13-week term or a 12-week term, and it was obviously compulsory for interns in Australia to do a term of emergency medicine because they didn't get their registration until they completed their intern's year.
So, Michael, tell me about the Queensland Emergency Medicine, the Queensland Emergency Medicine Research Foundation.
When I first qualified, I would tell my friends that we were so busy and so under-resourced that virtually everything we did was clinical care for our patients. When we got a little bit more resourced, we were able to spend more formalised time in education. So we always did education of the interns and the residents and the nursing staff and occasionally the paramedics, but then we had a more formalised training program for our registrars. And then when we got a little bit better resourced again, we were able to do research. And so to get funding for emergency medicine research, we managed to get the Queensland government to set aside a small amount of funding, and we used that to launch research in emergency medicine in Queensland.
Okay. And since then you've been attracting research teams, and you yourself, I think, have got 40 publications.
It might even be a little bit more now, but I think the area of research that I was most interested in was staff safety. Yes. And in particular, the relationship between staff safety and patient safety. So we published a paper in the BMJ over 10 years ago where we said that we said that staff safety was a prerequisite to a good culture of patient safety. And we noticed over the last decade or so that that's becoming more and more recognised and accepted.
And tell me, is this the reason that you started Qlicksmart?
No, it's interesting. We started Qlicksmart first. So I worked with Dr. Neville Henry. So Neville Henry worked in the general practice area of the emergency department. And Neville was one of the most modest men I ever worked with. He did medicine, then went to Papua New Guinea to work. And while he was in Papua New Guinea, he was given a scholarship to do a Masters of Public Health at Harvard University. Neville did a lot of work for the International Red Cross. And so he worked in multiple places, including in Rwanda. So he went there and headed up the Red Cross intervention for the second 3 months. And Neville, based on all the work he'd done for the International Red Cross, was given an AM, which is an Australia Day award. Anyway, when Neville was working in the general practice area, he did most of the simple procedures. And one of our friends and one of our colleagues, Anne Todker, was a nurse, and she was in charge of the general practice area. And Anne said to Neville one day, there has to be a better way. And she pointed at an old sharp spin with a bit of endotracheal twill and a pair of old rusted artery forceps. And so what she used to do at the end of the procedure was she or one of the enrolled nurses would remove a scalpel blade with that equipment. And literally that weekend, Neville went home And in his garage under his house, he built what eventually became the world's first single-handed scalpel blade remover. And I jokingly say that the only thing we ever stole from the hospital was an old cyclosporin jar, so a plastic jar, and Neville put the first of his inventions into that.
Fantastic. So that's great. I wasn't aware of Dr. Neville Henry, but I will look into that. Thank you for that. So tell me, from those humble beginnings, how did the company get started and where did it get started?
So I tell people, although this is not quite 100% correct, but Neville went to Rwanda.
Yep.
And I went to visit Becton Dickinson in New Jersey. I had an appointment to meet the person who was in charge of reviewing other people's inventions, and somehow he'd gone on holidays. And no one else in the company would speak to me because they'd been sued a few times for stealing other people's ideas. So that was a bit deflating. And then I flew to the UK, caught a train to Sheffield. And for the first time in my life, there was someone at the train station with my name on a card. First and only time, I should add. And so Swan Morton picked me up. And I went down to Swan Morton, and they're a fascinating company. They were the only scalpel blade I'd ever heard of, but Swan Morton is basically 50% owned by the company and 50% owned by the staff. And so they have staff that have worked there for 50 or 60 years. So they were run by 3 senior people, and they took me on a tour of their manufacturing facility. And it was the first time I'd ever seen quality assurance in place. So they said to me at the end of reviewing our product, they said that it was the best scalpel blade remover they'd ever seen, even though they had their own, but they didn't have the resources to commercialize it, which I thought was a very polite way of saying nick off. But in my naivety, when we got home, Neville and I decided to form a small company, and with a loan from the federal government, we commercialized Neville's invention.
Oh, fabulous.
And so we did that for about 5 years, and then we realized that the mindset and the skill set required to commercialize a device is very different to that required to sell a device. So we established a second company called SmartStream, which is basically our channel management company. And under Chaminda Connor's leadership, we sell the Qlicksmart range of safety devices in 55 countries to a network of 140 or 150 distributors.
Fabulous.
And then 5 years after that, we realized that counterintuitively, healthcare is very bad at staff safety. And you hear that from people in all industries that have anything to do with healthcare. We're shocking at it. And so we formed Staff and Patient Safety to advocate for improvements in staff safety. So when you go back to your original question, it wasn't the observation that staff safety is required to build a good culture for patient safety that led us to forming Qlicksmart. It was actually Qlicksmart that led us to that, because it's quite interesting that when I was working for Qlicksmart, when you look back in at your own workplace, you see things that you're oblivious to. And I think the psychologists refer to that as the deviation of normal. And so we had 3 paramedics showed us a device called CheckClip to reduce medication errors. And they were explaining how it was very easy to get syringe swap or ampule swap, leading to injection of the wrong drug into the patient. And when I was aware of this, when I was working in the emergency department in resus 2 or resus 3 for a trauma, I then noticed those little kidney dishes that would have 2 syringes and 2 ampules, but they weren't connected. So that had been happening probably most of my professional career, and I had never noticed it because that was our normal. And so only when we stood outside and looked back, we were able to identify how badly we managed staff safety.
That's interesting. How does the system work? Have you adopted that system inside of your organization?
Yeah, well, we're an ISO 13485 accredited company, again, under Chairman Carlos's tuition. But what we published is the culture of blameworthiness. So in 1999-2000, the Institute of Medicine published the To Err is Human report, in which they identified there were 50 to 100,000 preventable deaths in healthcare in America every year. And depending on what report you read, can be somewhere between the third and the sixth commonest cause of death in America is medical error. And in the book, they said that staff safety was important, but staff safety would improve when patient safety improved. And we think the exact opposite is the case. But when the To Err is Human was published, there was a British psychologist called James Reason, which I've always thought is a great name for a psychologist, published the idea of the Swiss cheese model. And so what he's saying, if you stand a piece of Swiss cheese up vertically, it's very easy to shine a light through one of the holes. If you get two side by side, it's a bit harder. And so his hypothesis was when you had 5 pieces of Swiss cheese, it was very hard to shine your light through it. And so his argument was that doctors and nurses don't go to work to hurt patients. And so when patients have bad outcomes, it's a result of a systems error. And the classic case he reported, and I'll shorten it a little bit, but there was a young man in a hospital in the UK with lymphoma with cerebral metastases. And so he had an IV cannula in his arm for morphine and for his chemotherapy agents. But because his headaches were so bad, he had a CSF cannula inserted. And on a Sunday morning, an intern came along, said hello, introduced himself, explained what he was going to do, but by accident injected the chemotherapy into the CSF. The young man fitted and died a few days later. And when this was reviewed, the first thing was it was an intern. And when I was an intern, in retrospect, when I was an intern, I didn't know much what was going on. Secondly, the charge nurse, who I've always found to be the most important key for patient safety in a ward, was acting in a different position. The third thing was the oncology pharmacist was away, and her replacement had little experience with chemotherapy. And then because it was a Sunday, there were less staff around. And so the theory is that if any one of those 5 issues had not occurred, the error would have been picked up before it happened and the patient wouldn't have suffered that injury. And so to try and improve this, and it's based on a bit of research done by NASA as well after one of their aircraft shuttle crashed back to Earth and everyone died, is a no-blame culture. So the theory is, Stephen, you're my boss. If I make a mistake, in the old days, if I told you I made a mistake, you'd yell at me. And I saw a lot of that when I was a younger doctor. But if I say to you, Stephen, I've made a mistake, then what we can do together is we can go make sure the patient's okay, even if there's no bad outcome. And then you and a few other clever people can work out what can we do to prevent this error occurring again. So if we go back to the Swiss cheese, what can we do to plug up one of those holes? And that makes sense.
Are you doing that sort of consulting work at all?
Oh, no, we publish and advocate for this. But so that was the no blame culture. But our observation was that staff still work in a self-blame culture.
Yes, indeed.
And we published that there are 3 reasons why staff don't report their injuries. Firstly, it's denial. They don't think it'll happen to them. Secondly, it's if you take a risk for your patients, then that's okay. And the third thing, which worries me most of all, is you blame yourself. And I'll give you an example of that in a minute. But our hypothesis is that it's hard to believe, if not impossible to believe, that one person can operate in a split mindset. No blame culture for patients, but self-blame culture for staff. And we think that's the root of one of the major problems with patient safety events in healthcare today. So this became apparent when, over the period of about 4 weeks, 3 of our registrars in the emergency department had sharps injuries, and they came up and reported them to me. And the first one was looking down at the ground, very despondent, very ashamed, and said, oh, it was my fault. I was rushed. Meaning that he would never have another sharps injury if he was never rushed again, which is impossible. But then probably about a year or 2 later, I was working in what we call our observation bay. And one of the nurses, who was 4 or 5 months pregnant, was attending to one of our drug and alcohol affected patients, and he kicked her in the abdomen. And so she came up to me a bit teary and said, oh, it was my fault I got too close. And it's nonsense. It's not her fault. It wasn't their fault. It was an accident in the first case and it was an act of violence in the second case. But we still believe that it's our fault. So we don't report it. And if we don't report it, it never gets fixed. And if you look at healthcare as the big picture, we've got people trying to do all this no blame culture to improve patient safety and ignoring that for staff safety. So one of our big goals is to have one safe culture for staff and patient. And what we've been doing more recently is harmonising tools for patient safety with tools for staff safety and vice versa.
So the tools for staff safety, could you tell me something about those?
In very simple terms, risk management or risk assessment, and then the hierarchy of controls. So the risk assessment tells you what injury is likely to occur before it does occur, and the hierarchy of controls is the systematic approach to prevent that injury once it's identified. So the hierarchy of controls is fascinating. So I studied medicine, did my specialist training, worked for a long time, and I'd never heard of it. One of our staff here pointed it out. She'd heard about it at school, but it goes back to the 1960s in America when it was introduced to replace the behavioural model of staff safety. So in the first instance, what they used to do is try and change human behaviour to prevent injury. So they would educate, they would train, they'd cajole, and they'd punish people. And as you can imagine, it didn't work. You might remember in the old days, you'd drive past, or you'd see it on a movie, driving past a manufacturing plant, they'd say it's 2,000 days since we've had our last major injury. So the idea of the hierarchy of controls was to change the environment to make staff safer. And so it's an upside down pyramid, and on the top it says eliminate the risk. The second level is to substitute the risks. The third level is engineering controls. So in engineering controls, it might mean that if you've got a manufacturing machine, you physically can't get your hand in until it's turned on. And in sharp safety, it means you would use a single-handed scalpel blade remover. The fourth level is administrative control, and the bottom level is personal protective equipment or PPE. And so during COVID, all we ever heard about was PPE. And I would imagine that most people thought the solution to staff safety during COVID was PPE, whereas in fact PPE is on the bottom of the upside down pyramid because it's the least effective. And so our message is that PPE is important, but it should be used in conjunction with and never as a substitute for the higher levels of control.
So is there any real-time monitoring or predictive analytics that are used for this sort of thing?
We came up and published a model of using purchasing data, but unfortunately that hasn't taken place. And we published that paper as well.
Okay, I'm sorry. There are smart technology solutions to do this sort of thing currently out there.
Oh, sorry. So there are engineering controls to reduce the risk of Sharp's injury, and that is some of the inventions that Neville made.
Yes, indeed. And are you still continuing to make inventions inside the organisation?
So we do two things. Internally, we are at the moment, we have probably 5 or 6 inventions in the pipes, and that includes updating our current products as well as a couple of new inventions. And we also spend a little bit of time every year talking to and discussing other inventions with people who've come up with clever ideas.
Excellent. Okay. Now, if there are young inventors watching this podcast or there's commissioners, how do they just pick up the phone and have a talk to you? Is that what they do?
I think we'd be very happy if they were to send us an email and then we could contact them. And the advice I would give them is that you have 3 choices. So let's say it's you, Stephen. The first choice is you can do it all yourself from start to finish.
Yes.
And I would say that in this day and age, that's virtually impossible. I think what Qlicksmart managed to do was quite unique and would be difficult to replicate.
Yes.
The second thing you could do is you could go to a big multinational, tell them you've got a great idea and ask them to commercialise it for you. And I think that's also very difficult because probably over the last 15 to 20 years, we've observed a change that what they will do to you is say, Stephen, that's a good idea. You go away and prove it works. And if it works, we'll come and buy your company. And the third option is to work with a small company like Qlicksmart and SmartStream, where you would have more input into your invention, and you would we would have probably less reach than a multinational, but you would get to see your invention in practice. And I've always believed that, let's say you're the inventor, Stephen, the thing you want most of all is to see your invention being used, because it validates your idea. The second thing you'd like to do is make a lot of money, but that's a lot harder.
It is extremely hard. I think that's very good advice. I love that. Thank you very much.
And I think the best advice you can give a new inventor, even though it's the last thing they want to hear, is to tell them, no, this is a bad idea. Because we've done a couple of projects that haven't been successful, and in retrospect, we should have picked the signs a little bit earlier and stopped earlier. But one of the advantages we have now is we looked at a device invented by an anaesthetist to improve ventilation of patients with beards, that then became a potential safety product during COVID.
Yes.
However, we were able, through our network of distributors, to get clinical input into the device, probably in 6 or 7 different countries, and they all said no, and they all said they wouldn't pay for it. So that meant we saved that person a lot of time and money by not continuing at that invention.
That is a great message. I love that. Thank you very much for sharing that. I think that I think there's a lot of people we're aware of that would love to engage with you on that basis alone. So Michael, in conclusion, is there anything you'd like to tell us both about the future of Qlicksmart and patient safety?
I think the future of patient safety is staff safety. And what I would like to see is that when a hospital gets accredited, it should spend, if not equal amount of time, 30 or 40% of their time should be looking at staff safety. Because it's funny, Stephen, if you think you're a patient, in theory, if you go to a hospital that's been accredited, you know the standard's pretty good. But if you just qualify as a nurse or a doctor or a podiatrist, and you go to work in a hospital, you've no idea whether it's safe or not, do you?
No, you don't. That's a good point.
And when we talk about staff safety, we talk about physical safety as well as well-being, and they go hand in hand.
They do. Sorry. All right, Michael. Thank you very much for your time today. It's been great to see you again, and I wish you all the very best. I'm pleased you're achieving what you're achieving. So thank you.
Stephen, always a pleasure to speak to you. Every time I speak to you, I learn something new. So thank you very much.